Hello, hello. We are kicking off on time because I've got this crowded house ticket, and I've got to be there by 8:30. So you know what macular degeneration is, and you know that the first signs are with drusen, and drusen. This is a normal, healthy retina, and they've got the retinal pigment epithelial cells. Bruch's membrane, and then the choroid here, and a normal retina. And the early changes are where there's accumulation of drusen, lipofuscin material, and the like that between Bruch's membrane and in Bruch's membrane and under the RPE. The AREDS study sort of graded macular degeneration into different types: early, intermediate, and late. And early is this little of small drusen, they call druplets actually, less than 63 microns. Then intermediate drusen that was sort of 63 to 124 microns. I hope you can see those maybe. And then and in an early macular degeneration, there's no retinal pigment epithelium changes. Intermediate drusen is something we tend to see more of, really, which is where you start to see the bigger drusen, and they're greater than 125 microns, and you can get pigmentary change with those changes. So you can see the drusen here, which I'm sure you've all seen and know. But this is where I was sort of more looking at the talk was, you have the intermediate or early drusen, but they then progress to the late macular degeneration or advanced stages. And there's two types: geographic, with this loss of the retinal pigment epithelium and the photoreceptor cells, and of course the wet. And it's wet that's dominated ophthalmology a lot in the last 15 years because we have a treatment for that, and injections have created a huge burden on the health system and ophthalmology. But geographic atrophy, we haven't had a treatment, and so it hasn't really been in so much in the spotlight. Just on that AREDS study, they did grade the risk of you getting a progression to wet or GA over a 4-year period, over 5 years, and if you grade it, do you have large drusen, yes or no? Do you have pigment changes, yes or no? And you in each eye, and then you grade it, and if you have one, there's a 3% chance that you would progress in the next 5 years to wet or GA, and by the time you've got 4 of those, there's a 50% chance. So it's just one of those things of looking in and see a few drusen, well, chance in one eye, probably not much chance of them developing a problem in the next 5 years. But if there's a lot of changes, there's a 50% chance in 5 years. But I'm talking about geographic atrophy, and geographic atrophy it's got this name from the fact that you've lost this sort of geographic shape, and it's sharply demarcated against the other part of the retina, and it's a loss of the photoreceptors, a loss of the RPE and the choriocapillaris, and if it takes out your fovea, then you get irreversible loss of vision, and there's loss of vision in the area where that atrophy is happening. There's a big area of atrophy right in the middle of here, and you can see the choroidal vessel, deep choroidal vessels under there, along with the drusen surrounding it, and so the prevalence is, they say there's various papers, but around 5 million people worldwide, and it has the same prevalence as wet, but there's more people go blind from the wet because of the damage caused from the leaking. Up until now anyway, the incidence of blindness from GA is probably increased, well, not the incidence, the percentage of people with blindness has increased because the number of people going blind from wet has dropped. So about 25% of blindness in the US and the UK is associated with geographic atrophy. And when you're over the age of 90, 22% of people will have some geographic atrophy, particularly in European races. There was Chakravarti did a study on the incidence of geographic atrophy in the UK, and the people that they had came 7.1% who were on diagnosis had vision worse than blind registration. 71% when they were diagnosed were ineligible to drive. Just these figures surprised me, to be quite honest. I'd like to think that we're better than this. 16% became legally blind within, on average of 6.2 years, and within a median time of 1.6 years, 2/3 of them had lost the ability to drive or pass the driving license test anyway. And just again to point out that dry and wet can go together. I shouldn't say dry. Geographic atrophy and wet should go together, because in that time 7.4% per year develop new vessels. So dry and just got to start saying dry. Geographic atrophy and neovascular macular degeneration can go together, and so that's something that people often don't realise, particularly the patients. And how does it? Well, it affects people significantly in their vision. The Snellen acuity surprisingly can be very good. You have the patient can read 6/6 and you're saying, wow, that's amazing, you're seeing really well. But they often have real difficulty with reading because there's patches missing in their vision. They have great difficulty in low luminance. So in our clinical studies, which I'll talk to you about a bit later, we take people and give them a Snellen chart, illuminated Snellen chart, and you can find they can, at 4 meters, they can read the chart. You then put the filter in to drop the luminance. And in one patient in our clinical trial, we have to bring the chart up to 1 meter before he can see the letters on that. So lighting and low luminance really affects them. They're very slow to DARC adapt. When they walk into a dark room, it takes them a long time to adapt. And most of them, you see them say, hey, look, you shouldn't drive at night in particular, because they get terrible issues with glare. And this is why they can see well. This is I love this. This is a area of atrophy associated with an autofluorescent study, and the photoreceptors are here. Now, it seems that one of the things is that rods get affected more than cones. So hence you get this little island that's still surviving, and they can move their head around. He's got, what's that? I don't know. I can't read it on there. It's 6, 6 or 6, probably 6, 7, 9 or something like that. And yet but that person will be moving their head around a little bit, going from letter to letter. But you go and test them, you think, wow, you've got driving license vision. That's fantastic. But you can see also why they would have difficulty with reading, because it's difficulty in scanning, because they are really literally reading word to word. I keep saying dry because I've tended to say that, but I realise I've got to stop saying it. And the reason for that is, I have to get that right for my talk next week, is that dry, what does it mean? Geographic atrophy was first used by Gass in 1970, and he just put it in as a description of macular degeneration and a few other things, but it's now sort of become used as the word for that atrophic stage of macular degeneration. Birdhow, in his description of one of the classifications of macular degeneration, used geographic to be the same as dry, and that's always been my thought process. Dry is when you've got to that atrophic stage and you've already got damage. But I realise now, I went and talked to a few people recently, and most often dry is meant to mean not wet. So patients come in, they've got drusen retinal pigment epithelial changes, they're intermediate macular degeneration, but they've been said, I've got dry. Now, the reason they're dry is because they're not wet. And so that's a little bit confusing. Also, in treatment, often after you've had intravitreal injections and the fluid's all gone, the doctor writes macular dry. I don't do that, but colleagues tell me they do. And then also you get this other complication of people thinking that I have dry eyes. And often it's the same thing with wet. You say, oh, you've got this problem of wet macular degeneration. Oh, yes, my eyes water, doctor. It's common. So from that point of view, I think dry is not a good term. And I'm not sure geographic is actually a great term either, but I think it's probably the one we're stuck with at the moment. So GA it's visualised now in the last 20 years in an amazing amount of imaging modalities. We've got your colour photograph here, and again you see this is picking out that atrophy with a little bit of retinal pigment epithelium staying in the middle, and that person probably sees 6/6. Fundus autoflourescence of the same patient, and remembering there's hypofluorescence at the fovea because of the luteal pigment, so often it looks dark right in the centre even though there's still cells there functioning. Then there's fluorescein angiography if you want to look for new vessels and leakage, and then there's of course OCT scanning, which can highlight areas of atrophy of the photoreceptors and the choriocapillaris and the RPE, and you'll often see on the OCT scan, which I'll show a bit later, this transmission of light going through because the pigment isn't there to block that light going through, and that's a common sign you'll see in patients with atrophic macular degeneration. And again, this is a M-colour photograph using a combination of coloured lights and this is here again atrophy, and you can see the choriocapillaris is gone, and you can see the big vessels of the choroid through that. And there's the autofluorescence study that goes with that. And just this is the same patient with the OCT scan through where he's fixating, and you can see the loss of the retinal pigment epithelium, the loss of the photoreceptor layers here, and the sort of collapse in of the retina. And again, that transmission of light because there's no RPE to reflect it. Fundus autoflourescence has become an important study in following people with geographic atrophy, and it's used as part of all the clinical trials. So again, this is where you illuminate the eye with 488 nanometer light or thereabouts, and the lipofuscin that's in the retinal pigment epithelial cells fluoresces, and you get this lovely appearance of a glow behind. Again, I was telling you about the luteal pigment, so because there's luteal pigment here, it blocks that 488 wavelength, and there's no transmission, so you don't get a glow there. And of course there's nothing happening in the optic nerves or the blood vessels, so they are black, and that's a normal eye there. However, if you get geographic atrophy, you get this loss of that fluorescence, and there's no light comes back when the cells are dead, so it becomes black. And then you can follow, these are different scans showing areas of people's fundus autoflourescence where the atrophy is enlarging over time. And so that's sort of where we are now in monitoring progression of geographic atrophy, and fundus autoflourescence is a major part of that. So I've just got a few here. Again, you can see these patchy areas of loss of the RPE and there's some calcified drusen and other things as well. And you can see here that there's this blackness here associated with that. And this is again following people along, and you just see people where they've got these areas of atrophy and they just start to enlarge. You can see here that's got bigger little spots are showing up, and so we're following, again, this is part of following people along and seeing, is their macular degeneration progressing? And this is another one where again you can see this area here, this area, this is joining up, this is joining up here. And just to notice here, this is this area here of what we call hyperfluorescence around the border. And this is probably where cells are dying and are in the process of degrading, and the lipofuscin is clumping, and so you get a hyperautoflourescence in that area. And that's another way we can look at how hyperfluorescence is associated with progression of macular degeneration. And so what this is just talking about, those areas of hyperfluorescence around the edge. So here's a patient here, they've got no, they're looking at, do they have fundus autoflourescence, hyperfluorescence on the edge, and there may be none. There may be just little focal bits, there may be banded areas, or it may be patchy. And then that's sort of focal, or it could be diffuse, where it affects larger areas, not just around the edge of the atrophy, but also around further out away from the areas of atrophy. And there's also a particular type called diffuse trickling, which has of all the types associated with it, tends to have the greatest progression of the atrophy. So how fast does these areas progress? Well, in the clinical trials, they've found that they can grow from about 0.5 millimeters squared to about 2.6 millimeters squared per year. But so that's out of clinical trials study, how much it is large based on baseline. But in taking a whole lot of studies and putting them together, not necessarily clinical trials, I found there's a huge variation of growth. But the clinic, this here is this group here. So there can be a huge variation on how fast these things grow, starting off quite large and a small bout of growth, and starting off quite small and a large area of growth in the size of the atrophy. So just looking at the areas of enlargement, what features do we see in fundus autoflourescence and other things that may suggest that things will get larger quicker? So if you have a small area of autofluorescence, then that will advance more slowly than a medium area like this. If you've got a unifocal, that's just one big lesion, that is slower progressing than these multifocal areas of atrophy. If it's at the fovea, it progresses more slowly than if it's outside the fovea. And then if you've got the bigger the area of hyperfluorescence, again, the greater that progresses. And then I just talked to you about those areas of hyperfluorescence. So, and this is an order of growth. If there's no fundus autofluorescence, the growth is extremely small, sometimes none. And then if you get to banded, it's increasing, and when you get to diffuse, it's even faster growing. So all these things are something we're looking at when we're seeing patients and trying to assess how quickly their disease might change and how they might, how's that going to affect their vision in the short and long term. The other thing was looking at OCTs. I mean, to say vitreomacular traction is probably a bad sign. It's regarded as being more chance of progression if you've got some vitreomacular traction. And the other thing, which is in particular, is reticular pseudodrusen, which I've talked about before, I won't talk about now. But if you have reticular pseudodrusen, the disease, which is almost a different type of macular degeneration, it progresses quicker than other types. Interestingly, it's often symmetrical. So if you look in, here's just different people with different areas of atrophy, and you can see that they're almost identical in both eyes. But that's not always the case. As far as enlargement goes, if you have two eyes looking like this, we know that this eye is likely to get worse quicker because the other eye looks like that. And certainly both eyes are going to get worse because these areas are larger. Where if you have an eye that looks like this, and the other, which is atrophy, and this eye has got just intermediate changes, then the progression is a lot slower overall in both eyes. I think that's showing the intermediate there. Just you're seeing drusen, but see the difference of the light going through? And this is the other eye, and you can see that transmission of light because those retinal pigment or the photoreceptors and the choroid capillaris have gone. So this is just looking at, again, growth. This is a patient with a unifocal lesion with the area banded, and its progression is, in this eye, was about 1 millimetre per squared per year. When you got to this multifocal lesion, that's in follow-up is about 2 millimetres per year. And then I was talking to you about this group of trickling phenotype. Then the progression is about 5 millimetres per squared per year, which is pretty rapid. And the other thing was just looking at how fast it grows. Fortunately, it grows faster away from the fovea than at the fovea. So again, that whole thing where you saw with that original photograph slide of the Snellen chart, small letter in the middle, it's remaining there because those photoreceptors are remaining, but it may be the area of atrophy may be getting larger because it's progressing out at the edges. So what can we do to reduce the progression? And the idea is that if you have a GA lesion area getting bigger, associated with usually the vision, as it gets bigger, the vision gets worse as it takes out the fovea. If you can slow that down, then the patient or the individual is going to see for longer. So that's where now a number of treatments are heading. And at the moment I'm involved in 3 different studies that we're looking at. One is the Apoptosis study, and that's in looking at the complement pathway, and that's you heard it here first. It's only been named in the last couple of months. It's now APL2 was the name of the drug, but now it's called pegcetacoplan, I think. So that's going to be the drug you might hear about in the future if this study comes to fruition. And there's another anti-complement treatment we're using, which is a sub-cut injection in the skin. So not an injection in the eye, an injection under the skin, which a lot of patients are quite keen on. It's easier to tell someone we're going to get into a clinical trial about something going to put a little something under your skin as opposed to sticking a needle in your eye. Don't know why, but that just seems to be a thing. And then the other study we're looking at is an injection into the eye of this drug, OPL1204, which is an anti-apoptosis apoptosis drug, and we'll talk about that in a minute. One of the things that is associated with the genetics associated with macular degeneration and with atrophy is that there's a high association with complement factors, and in particular complement factor H, and there has been polymorphisms of about 6 complement genes, which you see here, which account for almost 60% of AMD genetic risk. So there's a high association of alteration of the complement pathway and progression of macular degeneration. This is the complement pathway. It is a way of us fighting infections and other things in our body. There's the classical pathway, which is antigens and antibodies. There's things along this lecithin pathway, which is binding. Oh, that wasn't meant to happen. I have to sort that one out before next week. There's where you got the sugar residues on a bacteria. Is the pathway, and then there's another alternative path, the alternative pathway, but they all head to here, which is C3. I just make a point, and part of this alternative pathway is factor B, which we'll come to a little bit later. When it gets to C3, it then progresses to these other pathways and results in this membrane attack complex, or MAC complex, which causes cells to lyse and die. So this is in a normal situation. You've got your cells and photoreceptors, and this is the cell membrane, and you've got these different complement factors, and there are other factors, complement factor H and complement factor I, which are stopping the progression of that complement pathway. If that breaks down, then you can get that inflammation occurs and the production of this MAC protein, and that results in the cells dying. And in macular degeneration, loss of cells is then associated with loss of sight. So this is a study. This is a phase 3 study we're in at the moment, where we've got patients getting with geographic atrophy, getting the injection or a sham. And when they got this trial's now, we've finished recruiting. We got 5 patients in this trial at the moment, and I don't know. There's only one person in our is the nurse. I know there's 2 people. There's a nurse and the doctor who does the injection, who know if the patient's getting the drug or not. And in that trial, there's a 2 out of 3 chance that they're getting the drug, but 1/3 will be getting a placebo. They don't get an injection; they get fake. You do everything, but you don't put a needle in. And this is what this drug does: the APL2, which occasionally says no, and it works on here to block C3. And by blocking C3, it then stops all this other pathway leading to the MAC and cell death. And we're also involved in another trial before this one. This is called the OAKS. Now this is called we were involved in the Philly trial, which was the phase 2 study. You're probably all aware now of phase 1, phase 2, phase 3 because of all the COVID studies with injections. And phase 2 was the smaller study to see if it was worth going on to a bigger trial. And it, as I say, it inhibits C3 and stops the complement cascade. And in the study they were given an injection either every month or every other month, and they were followed for 18 months and compared to those people who didn't get the injection. And they found that the APL2 was independent of any complement factor I genotype. So, and they found that even when you discontinued the drug, at month 12, the treatment effect declined, but they were still getting an effect. And because of that FILLY trial, they decided they'd go on to the phase 3 trial, which I was talking about. So the result of the FILLY trial was that given monthly, the injection given monthly, resulted a 29% reduction in atrophy progression versus the sham. And if you had it every second month, there was a 20% reduction. And when it was stopped at 12 months and then looked at 6 months later, that did reduce to a 12 and 9% reduction. So even there was they were doing better 6 months after they had the last injection, but it was wearing off. So we're in this APL2 study now, and we're actually recruited, and we've got two. There were meant to be 2 sites in New Zealand, but as I understand it, I think we're the only one with patients in the trial. And that whole trial was exactly the same thing, giving the injections monthly or 2 monthly, and seeing whether there is a progression of the macular degeneration over time, and also to make sure that it was a safe drug to give. And they were patients. So once we found a patient with geographic atrophy, they had a lot of studies, and if they were then suitable for the study, they were then randomized to getting the injection every month for 2 years, every other month for 2 years, or getting a sham monthly or every 2 months. And just in that trial, they had to be over 60, and the area of geographic atrophy was between 2.5 and 17.5 millimeters squared. So it can't be too small, but if it's too big also, they don't get into the trial. And they had to have some of that hyperautoflourescence around the area of atrophy. So this is a patient that went into the trial. You can see the glow of the hyperautoflourescence, and that is, I can't quite read it, 3.32 is it? So that person could get into the clinical trial. And similar, another patient with an area of atrophy. And again, as I said, that's the fundus autoflourescence, hyperautoflourescence around the hypoautoflourescence. And I won't go into that. We have to do their visual acuity. The patients had to be better than 360 also to get into the clinical trial. And usually it's around that 360 to 660 to get in the trial. And they're also looking at how well they can read, and how also their normal vision, and also on a Snellen chart, and then that low luminance test that I was talking about. And we did these other assessments, including endothelial cell count, but in particular it's the fundus autoflourescence and the OCTs that is important. And actually in our clinical trial we're also doing microperimetry, because we're one of the only 2 places in New Zealand that has microperimetry. So far they've found encouraging results with this APL2 from the phase 2 study, and at the moment we're in the phase 3 multinational trial, and we'll watch this space. So far, well, we don't know how it's going because I'm blinded. We're masked, but it looks promising that might be a treatment for geographic atrophy in the future, but it also means having an injection every month or 2 months. The other drug we're talking about is the one that goes under the skin, and that works on this factor B here, which leads to the MAC attack, but it doesn't, you can see it doesn't, by affecting factor B, by affecting factor B, the other pathways are still working. So because we're blocking the production of the complement in their liver, and it's still important that they have some complement cascade to be able to work against infection and other things. And so this is working with what we call an antisense oligonucleotide drug, and they've already done the phase 1 studies and found it to be a safe drug, and now they're going on to the phase 2 study. And this is how it works. You have a gene that normally transcribes and produces, when it's being mRNA, produces a protein, disease-causing protein, which then you can attack that disease-causing protein with different biologics or other drugs, or alternatively you can try and stop the production of that disease-causing protein by putting in an antisense oligonucleotide. So what it does is it binds to the mRNA and blocks it and stops it producing the protein. And that's what this drug we're using at the moment is doing. So we're in this clinical trial at the moment. We're still recruiting, and so we're still looking for people with atrophic changes that may want to go into the clinical trial. It takes 3 months to get in. One of the things here they do need is having vaccinations themselves for pneumococcus and meningitis, because they have there's a concern that maybe if the complement is reduced, they could be affected by that. And of course, in times of other vaccinations going on, it's an interesting time to bring people into a clinical trial. But they're then going to get the drug or a sham monthly, and then they're going to be followed after that. The other study we're doing, which I think is really fascinating, is a drug that's stopping apoptosis. A lot of people say apoptosis, but we don't say. If you take away the apo, you say tosis. You don't say ptosis. So it should be, in my thing, apoptosis. So anyway, normal cell. Apoptosis is something that is normal. We do have our cells regenerating all the time, and some cells have to be got rid of to let other cells come through. And so we do have this process where cells start this process of programmed cell death, and they shrink, and you can see them finally break down and then disappear. Now this happens due to this receptor on the cell. So this is a cell wall here, and it has this receptor called a FAS receptor, which is also called the death receptor. And what can happen is another cytotoxic cell can come along, which has these things called FAS ligands, which can bind to the cell. They then produce a change on the inner surface of the cell in the cytoplasm to form this death-inducing sequencing complex, DISC, which then activates these different enzymes in the cell, and that then leads to cell death. And so this drug we're using here, ONL-1204, is a drug that blocks that receptor to stop those ligands from binding. And this is a first-in-class drug, and they've done the phase 1 study, and now are into doing phase 2 studies to see if it can have a role in stopping multiple eye diseases actually, but in particular we're looking at here as geographic atrophy. And so what that does is, I told you, you've got the FAS receptor here, and the FAS ligand wanting to come and bind to the cell and induce the apoptosis or other cell damage, but this drug blocks that. And so this actually is quite an exciting concept. And at the moment we're in this trial where we're giving people, once we get going, we haven't started yet, we're looking to recruit soon, different doses of the drug to see what effects that has on the progression of atrophy in the back of the eye associated with macular degeneration. And with those, there's a reading, there's two parts of that, again, assessing the progression of the disease, and there's a reading centre at Degeneration, Degeneration Eye Institute, which is in Los Angeles. And they will be looking at the OCTs and the Fundus Autoflourescence. But there's a second reading centre which is using this apoptosing retinal cell imaging called DARC. And this again is really fascinating. What they're doing there is we're injecting a drug, a fluorescent labelled drug, into the blood. When a cell is dying, this PS here comes to the surface of the eye. And so this drug annexin-5 protein binds to that, and so it binds to the cells that are dying or have got the apoptosis changing. So here's a patient here, and they've put that in. These little cells that are being outlined that have got starting the apoptosis pathway. And then using that injection, and then using artificial intelligence, they're being able to assess the progression of apoptosis in the retina. And the other thing about this that's quite exciting is that apoptosis occurs in a lot of our disease processes. And so at the moment they're already in different trials, phase 1 with rhegmatogenous retinal detachments and angle closure glaucoma. We're in the dry AMD study here, but they're also looking, more importantly I think, which will have a big role to play, is chronic glaucoma, because we know that apoptosis is a major cause of why cells die in the optic nerve, because they get started on that pathway and you can't stop it. And so we've talked about those other things in the 3 clinical trials that I'm involved with, but then this was just a paper recently, and that just went through all the different trials that are going on for dry AMD. And there's cells looking at neuroprotection, and including brimonidine, which has been talked about a lot. There's drugs that are looking at there's approaches looking at stem cells. There's looking at things called inflammasomes, and then there's the whole of the complement pathway, including the one we were just talking about here and here. So there's a lot going on at the moment in different drugs looking at the possibility of treating atrophic macular degeneration. So just in summary, there is an increased prevalence of geographic atrophy in the world as increasing numbers of people get macular degeneration. This is an increasing cause of blindness. OCT and fundus autoflourescence allow good assessment of a GA progression. There's multiple clinical trials going on at the moment in the world trying to look at options to treat this, including 3 which are going on here at Southern Eye Specialists. And hopefully this new technology is going to help patients to see better in the future. Any questions?
COVID. Yeah, I was reading in Science Daily that COVID and complement and AMD sort of people who have AMD have a worse reaction to the COVID infection. They're more likely to get it, and they tend to. And it's not just because of their age; it's a confounding factor, but it's because they have macular degeneration. This is what I read today.
Look, I can't. I couldn't comment. I can't. Off the top of my head, I can't think of that process other than that they have, if they're having alterations in complement pathways, which is an immunity thing in their eye, does it have an effect elsewhere? I'm not sure.
Yes, apparently there's some sort of tie-up. I pointed there, but I didn't bring it in.
So, because with wet AMD injections, the system's already so overwhelmed with so many injections, if the treatment for geographic atrophy becomes injections as well, how will it fit into the whole public system?
Well, I would say that it won't.
Yeah.
We were very lucky to get the neovascular macular degeneration. It took probably 10 years for it really to get going around the country. We had good places, and Christchurch was right into it very early. Lots of the other parts of the country didn't. If we didn't have Avastin, because it was cheap, I would have said we would have been struggling ever to have started treatment here. If we had Lucentis as the initial drug, I think a lot of people would have gone blind. So that's the thing with these things. Again, with both wet and GA, there are new drugs going to come along, but can we afford it? And is it going to be better than what we're doing already? I suppose it's going to be what the science says in the end. How good are these treatments? Do they make enough difference that it's going to be worthwhile the cost of actually going into the drug? I would say, based on where we went with neovascular AMD, GA is not going to get treated in the public hospital.
The treatment that you already do on medium-sized drusen with making it smaller, is this likely to kind of set back by a number of years that progression thing?
Yeah, well, actually, I did just throw this in at the end, because the 2RT laser, which we're doing, is similarly again trying. So we have people with intermediate macular degeneration have the drusen like that. That those in the lead trial where they had two groups of macular degeneration, one got the laser and one didn't, and they followed them for 3 years. That over that time, those people that got the laser had a 70% reduction in the progression to late AMD.
RPD?
Pardon?
What's RPD?
RPD.
The blue line at the top, 2RT.
Oh, sorry, reticular pseudodrusen. Sorry, because what they found is people with reticular pseudodrusen did not get a gain from 2RT laser. Sorry. So of the patients, so that took a quarter. They took those people out of the clinical trial and found these results. So it's a post hoc assessment, and some people say you can't do that, but I think you can with reticular pseudodrusen because I think it is almost a separate disease. They found a 70% in those people that didn't have reticular pseudodrusen. There's a 70% reduction to late AMD, and there was a 4 times less chance of them ending up with that dry or wet macular degeneration. So again, that was that same argument. That was some patients I've treated, and of course you notice that. The thing here is that drusen do disappear, but you'll notice in this patient the drusen have gone, but the retinal pigment epithelium is staying, and and the amount of light coming through there is pretty good. So they haven't gone to atrophy. So that's almost that same graph we're saying. If you can treat people here, and you can extend their vision would have dropped off to here, and then you've given the laser and it extends out their vision, then that's that same process. So so that's again, if you can treat people before they develop the GA or the wet type, then that would be better than having to treat them once they have a problem.
So that would be like second eye treatment if one's already got GA and the other's got intermediate drusen.
Yes, or treating them in both eyes before they develop either.
I think you can sell it better the one that's already got GA in one eye.
I don't know. I find a lot of people come in, they've seen their parents go blind, and
Yeah,
they're quite keen to.
So has it been your experience that this is true?
Yes, I mean that's. You can't say again into individuals, I'm going to treat you, and this is but if I just go, but if I go back to this sort of appearance here, that going to that, and their vision remaining stable. I've got a large number of patients like that, and there's just been another paper come out supporting those lead studies outside of clinical trials. I only arrived at my desk this morning, so I haven't actually fully read it.
Right, so this is prevention rather than trying to fix it.
Yes, it's trying to stop you getting to the point where you've got GA or wet. You're going to get in beforehand. Then if once they've got those GAs, what can you do about it, which is what was really the thrust of my talk. But
Yeah, the fence at the top of the cliff is always better. Are you allowed to tell us about how much it costs?
it's $1,400 per eye.
And how often do you need that treatment to?
The maximum number of people I've treated is 3 times. So in general, I'd say the average it might be two times a year apart. And sometimes they go well, and then they start after maybe 1 to 2 years. You start to see the drusen picking up again, so you go back and do another treatment. We were hung up originally of trying to see the drusen go, but we now realise that non-progression is also part of that same process. So,
Well, yes, as you're aware, there's an awful lot of MD on the coast because of whitebaiting. I reckon, in my 35 years plus,
yeah.
it's the whitebaiters that get MD.
Wow.
And it's just India, so it's really bad for your eyes, whitebaiting, and probably fishing in general.
The UV light, you think?
Absolutely. Out of the sky, off the water.
The other thing I haven't gone into about that whole GA thing, which is important, is now the technology that's out there to help people. It's almost another talk, but there's so much now that with people with GA can get help with from enlarging the font on their computers to things that can talk to them. I just got recently from Barry I just forgotten his name off the top of my head. The guy does all the low vision stuff, and there's a pair of glasses now you can put on, and you look it down. It reads it to you. So I've just seen the pamphlet for it, but so there's just a lot of incredible technology out there that is making life easier for these people. And Barry Burgess.
Criteria, like, who can we refer for the trials?
Oh yeah, well, thank you for that's one of the things main things to talk to you, of course, because I think you guys are the people who are seeing people out in the community who have got dry macular degeneration. He said, using the word dry, who've got that macular degeneration and that have come in to see you, who can still see well, but then you look and say, hey, gosh, you've got something going on, and they're the sort of people we'd like to see. They get screened for the clinical trials. There's no charge, so if you write in and say, hey, I think this person would be a candidate, we can bring them in and we'll obviously talk.
Signs of GA, basically.
Well, associated with macular degeneration.
What type of patients? Yeah, can you, like, what's the criteria to refer that they would be
over 60,
yeah.
better than 360, and then that haven't got wet, but and the different clinical trials have different sizes, but I have, unfortunately, there's a surprising number of rejections of patients who think they're going to be good because they've got a little bit of sign that could be wet, and if that's the case, they're out. And there's cataract, they got a bit of cataract, so that stops their being able to get good autofluorescence. So, pardon? We just have to say to people, look, there's a chance you could get. There's a clinical trial that would you could go into. In all clinical trials, you have to explain the clinical trial to them and decide whether. I mean, there's a lot of time involved for the patient in coming in, involve these things, and so they have to then feel that it's worth their while, that they want to do it. But it's fantastic the response we have from patients actually, and it's always disappointing to say sorry you don't make the trial because of something. So you guys are probably the best people to be referring, other than myself, really. Most of the people that have been in the clinical trial have come from optometry or myself. My other colleagues, it just doesn't seem to happen. So just think about it, and if we're happy to just bring people in, give them the information. We usually, if you said this person we would be interested, then we'd send them out the information about the trial and let them read it and see if they would be interested, and if they are, they come on and we do but it's a whole, they've got to have their vision done, they've got to have fluorescein angiograms and fundus autoflourescence and all those sorts of things to decide whether they read the criteria to go into the clinical trial. And then when they do, they get randomized to either different doses or to the sham. And again, it's understanding that in most of these clinical trials, there's a 1/3 chance that they would not get the drug. And that's again for them to think through.
So you're saying the initial assessment is free? Do they have to then?
No, there's no charge, and in fact, they do usually get something. We pay for their travel and other things. So they're not paid per se, but they are recompensed for cost.
Did you say 1% a sham?
No, a third. A 1 in 3 chance. 1 in 3 chance they wouldn't get the drug. 2 out of 3 chance they would. Sounds better if you say 2/3 versus 1/3. Yeah, as I say. Well, yeah, we are really. We're really interested, and I think even if they don't, that people really do enjoy finding out about their disease and understanding it more. And usually, it's that reassurance that, well, once, like I say to everyone, you're not going to go blind, and it's amazing how these people can hold on to their vision quite a long time. Thanks.
Thank you.